preventive oncology in daily practice, what every clinicians can realistically do, is an increasingly important conversation as cancer burden continues to rise globally. In this VH Global Expert Talk, we focus on how preventive oncology can move beyond theory and guidelines into everyday clinical practice. The discussion will explore practical, realistic actions that clinicians can take across specialties to identify risk early, implement opportunistic screening, counsel patient effectively, and enable timely referral, making cancer prevention a shared responsibility in routine care. To discuss this, I have with me Dr. Tanvi Sood. Dr. Tanvi Sood is a gold medalist in MD medicine with advanced training in medical oncology. She holds international certifications from MRCP UK, ESMO, Harvard Medical School, and the International Society of Liquid Biopsy in Precision Oncology. A recipient of multiple national awards, she currently serves as a specialist medical oncology at Prime Health, Dubai. Welcome, Dr. Tanvi. So, Dr. Tanvi, my first question to you is, how should clinicians define preventive oncology today?
Right. First of all, thank you so much for having me, and thanks for that kind introduction. I have been part of oncology now for almost 10 years now, and primarily my experience has been in India. Now I'm practicing in Dubai with Prime Hospital, and across the countries, I've seen that, cancer burden in itself is a very pertinent problem, be it any country, whether we are, working anywhere around the world, all populations are affected by it. It is a very, very big problem statement when it comes to the health of a general population. And we as oncologists, of course, our primary role when it comes to healthcare, as healthcare professionals, is to help our patients who are diagnosed with cancer or help them at arriving at the diagnosis of cancer. And then we're part of their journey there onwards. But a very big responsibility also lies in preventing cancer altogether, because now we are very aware that there are so many ways in which cancer can be absolutely preventable or detectable at a very, very early stage. So maybe our notion towards cancer prevention needs to be focused also on catching very early stages rather than absolute primary prevention in itself. We know that primary prevention is we completely avoid the occurrence and development of cancer, and very typically speaking, lifestyle modification comes at the top. And we know there are carcinogens that are available around us in the atmosphere, in the environment, and also as habits. So tobacco usage, and also air pollution now that is on the rise. These are factors that are already very well established, and there are things that can be done about it. Of course, refraining from any kind of alcohol or tobacco usage. These are the things that we talk about, or even using vaccines for preventing infections, because HPV infections or HBV infections like hepatitis B, hepatitis C, these are related with cancer development later on in life. Very preventable cancer being cervical cancer that is associated with HPV infections. So advocacy for vaccination and compliance and ensuring that these vaccines are also timely taken by all individuals overall helps in the primary prevention part of it, I would say. But what about secondary prevention? So awareness on precancerous lesions, awareness about detecting these cancers at stage 0. So when we say stage 0, when it is still in a precancerous state or the cancer is still limited, that we call in situ, it has not become invasive yet, it has not gone into the surrounding tissue yet. This is the level at which cancer is very, very, easily detectable, early detection, and also treatable. This is when the cost of treatment and the burden of treatment is also the lowest and the cure rates are the highest. So if I had to give an example, very commonly for breast cancer especially, we call DCIS as stage 0, right? So if all women are able to undergo mammograms timely, annual mammograms, as we say, 40 year and onwards, or if there are high risk individuals, we're able to do individual screening for our patients and also risk stratify them that, okay, here my patient is probably at a higher risk than average individuals at developing cancer in their lifetime. These are the patients, or these are the individuals, I should say, we can focus on for timely intervention. And honestly speaking, even in our OPDs, we are seeing people who are walking in with their own self motivation coming in for screening. And more, we are able to detect these stage zero cancers like DCIS for our patients also, and able to offer them surgery and complete treatment and hope for 100% cure also. So I do think that apart from public screenings, it's very important to risk stratify our patients also, and looking into their own individual past history, family history, personal history, and high risk factors. We should be able to individualize screening strategies and prevention strategies for our patients.
I think it's very well said that early detection and secondary prevention, these should also be the part of prevention per se. So it's not only the primary prevention we are looking into, we are also targeting to detect the cancer early. Right. And how do clinicians decide when a symptom warrants reassurance versus further cancer workup or referral?
Right. So, now we are seeing more and more, as I mentioned, that the patient profile is also very important. When the patient walks into our OPD with concerns, if it is a lady who is, let's say, postmenopausal, advanced age, or if it is a young individual but nullipara, meaning she's not had pregnancy in her lifetime, even till the age of 40 or so, or they are on heavy doses of, long-term doses of hormonal therapies or long-term use of oral contraceptions, something should alert in our mind that we need to look into their symptoms a little bit more acutely and closely, rather than just sticking to reassurance strategies. It is of course very, very important to reassure anxious individuals who have come in with anxiety about, do I have cancer, or is this lump cancerous? Many times it's fibroadenomas in the breast, or it could be hemorrhoidal bleeding, and they think that what if it is a colorectal cancer, and so on and so forth. Many times young individuals who are smokers, they are aware that smoking is not good for their health. So even the first cough will spiral them into a lot of fear that what if I have developed a lung cancer, so on and so forth. So these are stories that I'm telling you from my own OPDs when I come across patients. It's very important to, I think, profile them based on their age. And if I'm dealing with somebody who is nullipara, maybe 35, 40-year-old, and she's come in with with a complaint of that she's got a lump in the breast, and we are investigating it. Let's say we did an ultrasound also for the lady, and nowadays we notice that there will be findings like a BIRATS 3 finding. So now it's coming into practice that perhaps these are the individuals that we need to closely monitor rather than reassuring and sending back home, because in practice we are starting to see that when biopsy is done, we are starting to catch DCIS in such patients. We are starting to catch very early stage carcinomas in these patients. And same applies even for women who are on, let's say, long-term hormonal therapies, and incidentally they have gone to a gynecologist for any menstrual related history, maybe irregular menstruation, and we have opportunistically done an ultrasound for this patient also now. And this DDS has revealed that there is actually endometrial thickening. Rather than thinking, okay, she's young, it will be okay, it will pass on, something should alert us about her history and the overall presentation of the patient, the age of the patient, and the history of the reproductive history of the patient, the hormonal treatment of the patient, that no, she probably warrants further investigation. And we are nowadays even finding atypical hyperplasias with endometrium, and also finding invasive carcinoma component with it. And many times, when we talk to our patients, we are just as surprised as them, because we are used to practicing reassurance, But now we are becoming more and more aware which are the patients we need to keep either on very, very close follow-up, call them back in 2 months or 3 months, have that investigation done again, and chasing the so-called benign looking pathologies that can actually turn out to be invasive. So now I think the mind shift is sort of, it is better to chase it when it seems benign rather than waiting and it turns into invasive later. The patients are also very, very self-aware now, and they are starting to see us in OPDs with the earliest of symptoms. So rather than thinking, that pain is probably something that is non-specific and tumors are generally painless, I think we need to pay attention to the first early warning signs that the patients walk in with, and also pay attention to the overall profile of the patient.
Right. So I think aggressive investigation is what is required at the earliest sign. So talking about the investigations, what are practical examples of opportunistic early cancer detection that can be integrated into routine, say, clinical care without disrupting the flow?
Right. So, typically if a patient has come in for XYZ complaint, and if it's a female patient, at least in my own practice, I always take the opportunity to ask them, so have you gone through a breast cancer screening lately? When was the last time you got a mammogram done? And they could have come for either a breast related issue or any other complaint. So once we are in the flow of counseling the patient and trying to investigate them for their primary issues, of course, we don't want to deviate from it. Sometimes patients come with already diagnosed conditions, or patients come with specific complaints. But somewhere in our counseling flow, or when the individual is sitting along with their family members, especially, we always take the opportunity to, either ask them these questions in their history. Okay, have you gone through any other cancer screening in your lifetime? Breast cancer screening, colonoscopy, cervical pap smears. These are the common questions. Of course, age specific. We are able to ask for our patients if they are 40 and above, or if they have very strong family history. So these are the ones in which, we are able to target, especially for breast cancer screening. And I can perform a clinical breast examination right away if the patient is, of course, willing and understands the importance of it. Most commonly, patients are very happy to have, an examination completed. Apart from if they come for abdominal symptoms, we let them know, may I also examine your breast, or have you been practicing self-breast examination regularly? These are conversation starters, and it does make most of them think. They are actually very proactive, and they are very forthcoming about, okay, yes, doc, I want to, also undergo a mammogram. That's also pending for me. I haven't done it in a while. Or be it colonoscopies, we do talk about 45-year and above, and in the UAE region, even 40 and above, because we're starting to see colorectal cancers in younger individuals. So earlier it used to be 50 and above, and now the age is cutoff is starting to become lower, because we are seeing more and more young individuals affected with colorectal cancers, even being detected with early polyps. So some of them may have pre-existing history of irritable bowel syndromes, inflammatory, IBD, and they may have these pre-existing conditions that actually make them more prone or at high risk for developing cancers later, like ulcerative colitis, Crohn's disease. And they may have history of polyps in the past, or even something as simple as chronic constipation that can lead to, rise of higher chance of developing polyp because of the mucosal irritation. So these are things that are everyday problems, and they end up revealing some more information when we talk to them and have a conversation in the clinic, apart from family history and their own personal history, of course. So I do think that it does not disrupt our workflow. In fact, it adds to the overall value of evaluating and assessing a patient who's coming in with certain issues. Apart from their primary diagnosis, we're giving them a holistic picture of how to take care of their own body. If they are known smokers, we can direct them towards low dose CT scans, or if we're already doing CT scans, we have the opportunity to check the lungs also if there are any early nodules. In this way, we are able to detect cancers at a very, very early stage for these individuals. Many times, women who are coming from gynecology reference also for any other reason, we do ask them if a pap smear was done. And I must add to you that whenever I'm seeing reports also, because as an oncologist, a patient will come with reports done, investigations done. Even if it's a breast cancer patient or getting diagnosed for breast cancer, there will be a pap smear cytology report also. I don't even need to ask why this was done. So somebody is thinking, like all of us, when we are seeing our patients, we are thinking that, opportunistically, we should guide them for all these tests and have them done. They don't disrupt the workflow, they actually add value, and the patients are also feeling more reassured that they're overall looking into their entire health and all parts of the body that can be screened.
Right, and this is a very good message. I believe that it should become the inherent part of practice, like the mammogram, low dose CT, which you have said, and pap smear. These are something which are doable, and if you're looking for, say, one symptoms, maybe say a cough or bleeding per rectum, I think the other investigations should also be done to look into the history of the patient and to detect the lesions with the help of these opportunistic testing, we may say. How do documentation and follow-up, practices influence preventive oncology outcome, and where do clinicians most often miss these opportunities?
So I think the point at which the referrals are being done, maybe a patient had gone for constipation issues to his GP or gastroenterologist referred there further. And we need to have a closed loop communication between all the doctors, because patients sometimes they may not understand why a certain test was requested. Because let's say here in the workflow, a stool occult blood test was requested for a patient who has chronic constipation or has had history of irritable bowel syndrome, inflammatory bowel diseases, so on and so forth. And sometimes I think the meaning gets lost, or the patient is not understanding why we are doing a certain test. So documenting why exactly we are requesting for a test, it all goes into the system. And then, especially in countries like UAE, the system, we have everything fed into the system, and the next patient, the next doctor will be able to access it as well. So the entire history gets documented. Or even in India, when we are practicing, everything written in the EMR with explanation why we are doing something ends up helping the next doctor in understanding the intention of a certain test. And maybe perhaps sometimes the history gets lost while communication. Patient may be more focused on another history and forget about giving a certain information to the patient. So documentation becomes very, very important for closed loop communication. Or we just pick up the phone and talk to our colleagues and let them know. So I have incidentally found a stool occult blood positive report for this patient who's come in for constipation for the last 3-4 months, and I feel that this patient requires a colonoscopy because has a strong family history. So all of these points become very important. They're like building blocks into why we are doing a certain test for a patient. They also many times help us in obtaining the correct insurance approvals also for our patient, and why are we doing what we are doing, and also supporting from the of course international guidelines, that evidence based strategies why we are doing certain tests that we are doing. So closed loop communication will help us in sort of informing our colleagues why we are doing something. Patients will be aware, medical reports will be fully updated, and we need to, of course, update the reports also. If I have done a colonoscopy after this and a polyp was detected, we need to have a discussion. Polypectomy is done, now the report has come back, that report needs to be documented with the timeline. So then we know that this patient perhaps is at a high risk, needs a next follow-up, requires a follow-up colonoscopy, and even if it's a high grade, just adenomatous polyp right now, this candidate becomes a candidate for earlier colonoscopy rather than after 5 years or 10 years. So this individual will require maybe in another year for a reassessment, and after 3 years, 5 years. So, many times documentation is the very key. And when we are going through the entire document, many times it is like a moment for us also, okay, this is not something that the patient told me, but it's mentioned very clearly in my document that this patient has so and so history, especially family history, or any prior mutation tests, any, like BRCA mutation tests, or even for liver, syndromes for our patients of colorectal cancers. So these things are also oftentimes documented that patients may not necessarily understand that have gone through a sophisticated test. They may understand, some of them may sometimes understand, yes, a molecular test was done, yes, a test was done that was requested, that required, let's say, like a specialized lab for testing. But they may not always know the implication of the test. So from our side, it's our responsibility to document very well what we are asking for and what the results were, with a clear follow-up plan for our patient. This is how we'll be able to catch most of the individuals, especially the ones who are at high risk. In case they do end up developing cancer later, these are the patients who require closer follow-up and counseling, and also a very clear follow-up plan that you are, required to come back in the next 3 months or 6 months or 1 year for a follow-up test. So I would say, lab trends are also something that get missed. That patient has done a health package at any point, and maybe now I'm seeing more and more PSA, CA125, even CA19-9, like tumor markers, they are all included as part of the health packages. And patients are very aware if a single report comes as high, so because it is in bold, so they are very aware. They'll have a encounter with a physician maybe once, but perhaps the follow-up may get lost. So not one absolute lab value is important. We need to follow trends rather than a single absolute value. And in that case, again, documentation and the next follow-up and complementary test. Do I need to, get an ultrasound done? Of course, these tumor markers are not part of regular screening programs. But if it is done and got to be high, then it should not be ignored. Then we have to respect and honor the report, and we have to follow it up before putting the patient into reassurance category.
So I think the documentation not only helps us to diagnose a patient, but also to set the frequency of follow-ups and how aggressively you should, tell this to the patient, okay, get yourself investigated. That is very important. And risk stratification is also something which you talked about, is very important if there is a family history or if there is a genetic testing positive. Ma'am, just tell me, if you had to recommend 3 preventive practices that every clinician can realistically adopt, what would they be? Dr. Tanvi?
So, 3 prevention strategies. To my mind, the first thing that comes is, of course, opportunistic screening, because practically speaking, yes, public programs can be in place, but who is motivating the individuals? So unless you're in, corporate jobs, or you're in jobs where your health packages are supporting you and kind of giving you the platform to have yourself tested almost annually, or age-specific screening, there is no other touch point where a lot of our population is being motivated to undergo screening. I do think for every doctor who's sitting in the clinic and is face to face with another patient, it's a good idea to ask a lady about, breast self-examination practices, and when was the last time they did a mammogram, if whether they have a family history of malignancies or not, and try to just stratify if they're, a high-risk individual or not, or even age-appropriate screening if it's being done or not. So even in my practice, whether a partner or a spouse is sitting along with the family member, when they see somebody diagnosed with cancer, they also are very aware of their own health. The first question they ask is that, is this something that can spread to another person? Or if my mother has it, is it necessary that I also have cancer? We are able to, of course, pacify them and allay their anxiety. But at the same time, we also ask them, like, do you have any chronic usage of, let's say, tobacco or anything else? Especially for husbands, we do ask these questions. And many times, history comes out where the husbands are even more negligent, or, the wives or the partners are even more negligent of their own health and not taking care of themselves. So sensitizing them, using that opportunity where you're one-on-one with an individual and they have history of cancer in family, or, in the person sitting next to them, they are more aware and they're more likely to listen at that point. And opportunistic screening, counseling prevention strategy counseling can be done. We can talk to them about colonoscopies, as we have discussed. For older men, we can talk about PSA testing, we can talk about mammograms, and also the role of MRI breast if it is, a hereditary syndrome in the family, how other individuals can also go through genetic testing to understand if they're carriers of these gene mutations or not, and of course, cervical cancer testing, pap smears, how can be done, in families, whether they're vaccinating the young boys or girls or not, and after the age of 21, are they following pap smear cytology or not? So one thing is, of course, opportunity to talk about it. And when they're sitting in front of you, better not to miss it. Second is, I believe now more and more, when we are, especially in modern society, we are seeing women who are having children later in life, and social counseling is also important. Talk about early childbearing or the benefits of breastfeeding, and also how it is protective for breast cancer. These are such, we are all very career focused, but these are things like what our grandmothers used to talk. They're very preventive for, they're actually preventive for especially breast cancers. So we do talk to women who are in this age group, even if they've come for any other issue. So about childbearing and their menstrual history, also about reproductive history, and what are the benefits of these practices, especially for breast cancer, and not to let go of BIRATS 3, especially if it's younger individuals. So closer follow-up, and as we are talking about, early detection is very, very valuable, not just absolute primary prevention, but detecting cancer at a stage where it is stage 0 or stage 1, highly treatable, highly curable, and even the very cost effective. The overall treatment burden is also low at this point. So these would be my main three strategies that I do continue to follow in my practice, and I'm sure, and I hope that my colleagues are also practicing.
Right. So on that note, I'm sure that those who are listening to us must have taken some key takeaways from it, and definitely they will do these things in their practice as well. Thank you so much, Dr. Tanvi, for joining us.